So in terms of behavioural definition of sleep, so we define it as a lack of mobility, closed eyes, reduced response to external stimulation, characteristic sleeping posture, and recurrent reversible unconscious state. There are lots of functions of sleep. Some of them include energy and conservation and recovery, helps to regulate our immune system and improves response to vaccines. It also helps restoration of tissues and growth, regulation of blood pressure and heart rate, restoring hormone levels and digestive system. It's very important for memory consolidation. So in terms of declarative memory, it's explicit conscious recall of facts and knowledge in terms of episodic and semantic memory. During non-REM sleep, information is remember the one that is simple and emotionally neutral. Information that is more complex and emotionally charged is consolidated mainly in REM sleep. And sleep spindle's role is consolidating newly formed memories. Now, procedural memories such as playing the piano or riding a bike is also consolidated during sleep as well. And that's also consolidated mainly in REM. Lymphatic system, so it is a cerebral macroscopic neurotoxic waste clearance system in sleep, as for example beta amyloid by exchange of between central cerebrospinal fluid and interstitial fluid. Astroglial cell perivascular channels promote efficient elimination of soluble proteins and metabolites from CNS. And it also helps to distribute non-waste compounds such as glucose, lipids, amino acids, and neurotransmitters. Lymphatic function suppression may contribute to pathology in neurodegenerative disorders. Now, when we talk about sleep and wakefulness, we sort of tend to refer them as states. So nucleus suprachiasmaticus is a wakefulness drive in terms of sort of a part of the brain, but also what we have is homeostatic drive as well. So as we are awake, adenosine is building up in our brain, and that helps us to fall asleep at night. So for example, if we are a little bit tired and we try to keep ourselves awake with a coffee, caffeine blocks adenosine receptors. And when these receptors are saturated, when we are extremely tired, we just fall asleep anywhere, and we can no longer sort of have anything productive done that day. And obviously sleep, it has non-REM and REM sleep, and I'm just going to talk a little bit about that in a minute. So during first stage of sleep, we have eye sort of rolling movements, or slow eye rolling movements. Then we progress to stage 2, where we can see K complexes and spindles. And then we have stage 3 and 4 sleep, which is a slow wave sleep. And that's the most important part when we talk about restoration of hormones and tissue growth and memory consolidation. And obviously we've got REM sleep, where most of the dreaming occurs. Now, in terms of sleep history, it's important to ask whether somebody is right-handed or left-handed. Most of you would like to know why we talk about that in sleep. So the reason for that is that sometimes people suffer from sleep disorders, or what we call parasomnias, and in fact it is frontal lobe epilepsy. So therefore it is important to know which one is dominant hemisphere, because it helps us sort of in terms of diagnosis if we think about epilepsy. So if somebody is experiencing any unusual episodes in their sleep, such as sleepwalking or sleep talking, it's important to find out what time they start, how often they happen, and when did they begin. We also take a history about usual sleep patterns, such as what time people retire to bed, how long it takes them to fall asleep, whether they wake up during the night. We always ask about symptoms that could potentially indicate sleep apnea, such as snoring, apneas, morning headache, and how they feel the next day. So if sleep is not a problem for a patient, it should not be a problem for us. Also, it's very important to ask whether the patients have daytime naps, because that sort of helps us to understand them a little bit better, and to find out about hypnagogic or hypnopompic hallucinations, nightmares, night terrors, sleep paralysis, cataplexy, daytime sleepiness, restless legs, and any symptoms that could potentially indicate nocturnal seizures. One of the scales that is very easy to use, and patients can fill it in themselves, you can Google it if you like, and it sort of helps us to make a decision whether we should or we should not refer the patient to sleep clinic. So patients have to answer questions how likely they would fall asleep in certain situations. These would include sitting and reading, watching TV, sitting in an active place, or sitting in a passenger in a car, lying down to rest in the afternoon when circumstances allow, sitting and talking to somebody, sitting quietly after lunch without alcohol, or sitting in a car while stopped for a few minutes in traffic. So we score those patients score from 0 to 3 for each answer. Now, if the total score is about 14, we must refer that patient to sleep clinic. Some somnologists would suggest that probably we should think about referring somebody to sleep clinic if they score above 10 or above 13. Now, we've got sort of objective tools to assess the sleep. So one of them is called actigraphy, and you can see the device up here on the slide. So it is continuous recording of activities, so we can use for days or weeks. It basically records the movements. It's not intrusive, it's inexpensive. It's more reliable than just sleep diaries because you have some more objective data. However, there's no standardization, and what I mean by that is we don't have sort of standardized data for gender or for age. And we have no information about sleep architecture, so we just can sort of estimate, arousals. And it is helpful if polysomnography is unavailable. So gold standard examination or investigation for sleep disorders is polysomnography, which measures brain activity, eye movement, airflow through the nose and mouth, chin muscle tone, cardiac activity, thoracic muscle efforts during breathing, abdominal muscle efforts during breathing, level of oxygen in the blood, and leg movements. Now, this is how it looks like in sort of typical sleep laboratory. It can be sort of done, some of the variations of it can be done at home. It is an expensive investigation, and we usually have in Birmingham, only one patient admitted in the unit at the same time. So as you can imagine, it is quite expensive, and the waiting lists can be quite long. Overnight pulse oximetry is predominantly used to diagnose sleep apnea. The advantage of it is inexpensive, it can be done at home, but disadvantage is that it gives us a lot of false negative results. So for example, if this investigation comes back as normal, the patient might still have sleep apnea, in which case the patient would need to have polysomnography. The new device is a watchpad. It's currently used in Queen Elizabeth Hospital, Birmingham, and we're just about to have it in the Barbary Centre, Sleep Centre in Birmingham as well, where I currently work. So it measures heart rate, oximetry, actigraphy, body position, snoring, and chest motion via 3 points of contact. It has 89% correlation with polysomnography, and American Association of Sleep Medicine clinical practice guidelines decided that it is technically adequate since 2017. Sleep disorders are classified by International Classification of Sleep Disorders 3. So just to raise awareness that insomnia is not the only sleep disorder. So it includes sleep-related breathing disorders, central disorders of hypersomnolence, circadian rhythm sleep-wake disorders, parasomnias, and sleep-related movement disorders. And now I'm just going to talk about insomnia. So it is a huge problem. The prevalence of clinical and chronic insomnia disorder in Europe and North America is between 17 to 51% of adults report insomnia symptoms. and between 5.7 and 25.3% of adults experience clinical insomnia, and between 6 to 14.8% of adults experience chronic insomnia disorder. The burden of insomnia is significant, so it increases the risk of depression and suicidality, cardiovascular mortality, accidents. It causes decreased job performance, increased absence from work, and use of healthcare services. Insomnia disorder, as you all know, appears in ICD-11. So it is defined as persistent difficulty with sleep initiation, duration, consolidation, or quality, despite adequate opportunity for sleep, and results in daytime impairment. Daytime symptoms include fatigue, depressed mood, irritability, malaise, and cognitive impairment. Short-term insomnia is defined when we have difficulty in initiating or maintaining sleep of less than 3 months, despite adequate opportunity for sleep. Daytime symptoms must be present. So if somebody does not experience any daytime difficulties, we cannot diagnose that person with insomnia. And we also need to be mindful that in the presence of other sleep disorder or medical condition, short-term insomnia can only be diagnosed if it is an independent focus of clinical attention. Chronic insomnia is defined when the symptoms occur for longer than 3 months despite adequate opportunities to sleep. So if somebody is very busy with their work and they just don't go to bed very late and they say, I can't sleep, this would not be insomnia. What we would call it's a social jet lag. So again, daytime symptoms must be present, and sleep disturbance and associated daytime symptoms have to occur at least several times a week for at least 3 months. Some people might show episodic course, recurrent episodes of sleep-wake difficulties lasting several weeks at a time over several years. And in the presence of other conditions, same as with short-term insomnia, it's diagnosed if it is independent focus of clinical attention. We can use insomnia assessment as a kind of 6-factor approach because that's all very important. So homeostatic, circadian, physical health, including comorbid sleep disorders, mental health, medications that could potentially disrupt sleep, and environment. In terms of history taking, when we have somebody with insomnia, so it's important to take the usual medical history, including medications, baseline investigations, full blood count, vitamin deficiency, thyroid function test, etc. Full psychiatric history, sleep history that we just spoke earlier. Actigraphy is helpful if we have irregular sleep-wake schedules, or if we suspect circadian rhythm disorder, or we're not quite sure what's going on, so we're not sure about the sleep diaries. Polysomnography is helpful if we want to exclude other sleep disorders, or if there is treatment-resistant insomnia and we would like to clarify diagnosis again. Insomnia in high occupational sort of groups at risks, so shift workers, pilots, large discrepancy between subjective experience and sort of what polysomnography measured sleep. But most people that suffer from insomnia do not require any investigations that sort of are usually done in sleep centers, such as actigraphy or polysomnography, and can be successfully treated. So there are new guidelines how to manage insomnia that were just updated in January this year. So they talk about short-term management, short-term insomnia and long-term insomnia. So in terms of short-term insomnia, we need to think about referral for a sleep clinic or neurology center if symptoms of another sleep disorder are present. We must address any circumstances and stresses associated with onset of insomnia, ensure that comorbidities are optimally managed. We have to advise about sleep hygiene. We should think about informing DVLA, or I usually ask the patients to do that themselves. If there are symptoms of obstructive sleep apnea, or especially if somebody is diagnosed with sleep apnea, there are primary hypersomnolence, such as narcolepsy, or any medical conditions or medications that can cause sleepiness. Sleep hygiene is helpful for everybody, regardless what sleep disorder the patients might suffer from. So we advise the patients to wake up and go to sleep at the same time. Regular exercise each day is helpful, but it's preferred to be first part of the day, because if they exercise late in the night, it might be harder for them to sleep at night. It's important to have an exposure to outdoor or bright lights, especially in the early afternoon. Bedroom must be comfortable, so it can't be too cold or too hot. Sort of should be dark and quiet. Bed should only be used for sleeping and having physical intimacy. Ideally, we should relax 1 or 1.5 hours before sleep and use this time to process daytime events, maybe write a to-do list. Also, if we cannot fall asleep within 15 minutes, but that doesn't mean that we should be watching the clock. But when we sort of stay in bed for about 15 or 20 minutes and we feel that we can't fall asleep, we should leave the bed. Ideally, go to the different room, or at least different part of the room if this is not possible, and do either something very boring or something relaxing. But whatever we do cannot have any pleasure or function, because if we read an interesting book because we can't fall asleep, we'll just keep going. If we start doing work, that will just keep us going as well, because we will be giving a function to our inability to sleep at that time. And helpful activities before bedtime include exercising just before going to bed, stimulating activities such as playing computer games, caffeine in the evening, smoking just before going to bed, reading or doing anything else in bed other than sleeping, going to bed too hungry or too full, daytime naps, because if we nap during the day, that could reduce our sleep pressure. So our sort of adenosine levels might drop, because adenosine will be sort of broken down during the daytime naps. And also, we shouldn't try to fall asleep if we're not feeling sleepy or watching the clock. So if sleep hygiene measures fail when we manage short-term insomnia and there is severe daytime impairment and insomnia is likely to resolve soon, we can consider short course, so 3 to 7 days of non-benzodiazepine hypnotic drug. We should not be prescribing hypnotics routinely, and we should not be prescribing hypnotics to older people, pregnant women or breastfeeding women. If sleep hygiene measures fail and we have severe daytime impairment and insomnia is unlikely to resolve soon, we should offer CBTI, which is cognitive behavioural therapy for insomnia. It includes stimulus control, sleep restriction, cognitive therapy and relaxation training. We can consider the need for adjunctive treatment with a short-term hypnotic or prolonged release melatonin if the person is over 55 years of age. If hypnotic is prescribed, preferably is short-acting, use the lowest effective dose for short period, ideally less than a week. If there is no response to the first hypnotic, we should not prescribe another one, and we should not be issuing further prescriptions without seeing the patient. And follow-up should be arranged, but that depends on the clinical situation. And again, if there's no improvement, we should offer cognitive behavioural therapy for insomnia if that's not have been offered already, and we need to think about the need for referral. In terms of management of long-term insomnia, so again, we need to think about referral to sleep clinic or neurology if symptoms of another sleep disorder are present. Address any triggers associated with maintenance of insomnia. Make sure that all the comorbidities are optimally managed. Advice on sleep hygiene, driving advice, and cognitive behavioural therapy for insomnia. Pharmacological management of long-term insomnia should be avoided whenever possible, but patients with severe symptoms or acute exacerbation, or we could have a hypnotic drug for less than a week, or we could have it sort of particularly temporarily as a sort of an adjunct to CBTI. Modified release melatonin should be considered for people who are older than 55 years of age. And if melatonin is prescribed, initial duration is 3 weeks. And if there is response to treatment, we can continue for a further 10 weeks. Now, if daytime functioning is considerably affected and CBTI did not work or is unavailable, or unsuitable, we could consider new medication, which is called daridorexant. And the length of treatment should be as short as possible. Treatment must be assessed within 3 months of starting and should be stopped if there is no adequate response. And if treatment continued, we need to assess efficacy at regular intervals. Also, we must provide information about insomnia, follow-up depending on clinical situation, think about alternative diagnosis if this is not working and the patient is not getting better, and again, think about referral to sleep clinic, and we should not be recommending over-the-counter treatments. So in summary, insomnia is a disorder that should be treated. Cognitive behavioural therapy for insomnia is the first-line treatment for insomnia, with or without comorbidities, face-to-face, whether it's individual or group or telephone, online, all work. So there are 2 apps. One of them is Sleepio. It depends where you live. So for NHS workers, is free. But in some areas, for example, in Scotland and some parts of England, it is free as well. So pharmacological options are available but should not be used routinely. And again, we should always consider comorbidities and the need for referral to sleep clinic. So thank you very much for listening, and I would like to welcome the questions.
What was this new drug you said that for insomnia? How does it work?
So it's a new drug, it's called daridorexant. It blocks action of neurotransmitter called orexin. So orexin keeps us awake, is in charge of wakefulness. So it blocks its action, so therefore it makes us more sleepy. This drug can be prescribed even by general practitioners. So it doesn't need monitoring renal function. It can be prescribed if somebody suffers from hepatic impairment, but it should be avoided in severe liver failure. And it has side effects such as drowsiness, but yeah, we already started prescribing it.
So how do you spell that?
Daridorexant. So I can go back in a slide. So if just so you could probably, yeah. Are you able to see? Daridorexant.
What advice should we be giving our shift workers? Because we know that shift work does
So the most common problem of people who work shifts is the fact that affects the circadian system in the brain. So there was some data that if you worked shifts for 25 years, your circadian rhythm in the brain will be damaged irreversibly. So we'll probably, we would have fairly low threshold to refer those people to sleep clinics. So we would be looking for circadian rhythm disorders. They might need to have melatonin, they might need to have cognitive behavioural therapy for insomnia, where we would try and shift their circadian system. Now, if somebody who just started working shifts, what I would advise is to not to nap during the day unless they have to go on a second night shift. So when you finish your night shifts and you're just about to come back to your usual working hours, 9 to 5 or whatever they are, I would say after the last night to try not to sleep during the day if you can and have an early night instead, because if somebody sleeps during the day, it will be harder for them to fall asleep at night, because it would affect the circadian system in the brain, but also it will lower homeostatic sleep pressure as well. And then things that would help to align circadian systems. So would be lots of bright lights, or something that helps us most to align circadian system is not melatonin, it's bright lights, ideally outdoor lights, but if not, we could use LED lights, and they can pretty much mimic natural sunlight. Also, eat as well at the same time as you kind of, you know, if it's sort of, if you're during the day, you probably would, if you want to go back to the daytime routine, you would have your usual breakfast and lunch break because circadian sort of, there are pacemakers in the lungs and in the liver as well. So kind of to help your body to come back to the usual sort of thing.
Do all people with hypnagogic hallucinations, should they be screened for nocturnal epilepsy?
With hypnagogic hallucinations, probably I wouldn't. But things that sort of that would sort of make you wonder, you know, or suspect nocturnal epilepsy would be things that would be, you know, if there's somebody says, I sit in my sleep and I don't remember, or sleepwalk, or talk in their sleep. So these sort of things would be suspicious. And sort of what we tend to do is if possible, ask a video of it. And also, it's important to know how often events occur and if they occur in clusters. So if the events tend to occur in clusters, there's more chance that it is epilepsy. Of course, obvious tongue biting, urine incontinence, but not necessarily. We had patients in our clinic that been referred for sleep disorder, and all they would do is just had a very stereotypic movement, just sit up in their sleep just for a minute. And actually, when we did further investigations, we concluded that they had nocturnal epilepsy.
Can I ask you two questions about medications? So there's medications which disturb sleep. Given how common you're saying insomnia is, do you think that attitudes towards prescribing beta blockers, say, and dopamine agonists, should be considered, and how much are they looked at in terms of when people present with insomnia? And also, I see a lot of people refer to me who have a treatment for sleep called mirtazapine, 15 milligrams at night for life. And I wonder what the efficacy, because this is going on all the time.
Yeah. So when it comes to beta blockers or any other medications that the patients might have when they come to our sleep centre, we always take a history of everything what they take. Now, if somebody had somebody who suffers from severe nightmares as a result of beta blockers, so we've had discussion with cardiologists to see whether they could offer any alternatives. So I would sort of approach very much each patient as sort of an individual, so there is no kind of one size fits all in all situations. Now, in terms of low dose of mirtazapine, quetiapine, there's no evidence, and yeah, we would not recommend to treat insomnia or any sleep disorder with those medications. Obviously, if somebody is depressed, then they would need mirtazapine, but perhaps not 15 milligrams.
No, but this is a really, really serious issue and goes to the heart of whether we're serious about prescribing and the standards that we adhere to. This is going on all over, and yet no one's bothered about it,
Yeah.
from what I can see. So it's fascinating to hear about new drugs coming along, making lots of money for drug companies. But this is serious, and I don't see any evidence that this is changing.
No, that's yeah, it's difficult, and I think one of the reasons why I think sleep medicine is slightly sort of, you know, is very difficult to get funding for things, because a lot of people, when they have sleep problems, they suffer in silence, or they present to different disciplines. And it's always a lot easier to get the funding because somebody who is acutely unwell and is about to commit suicide or to hit somebody else or have a heart attack, and the fact that sort of insomnia would present long-term health risks, it's a lot more difficult to prove. But in terms of cognitive behavioural therapy for insomnia, so sort of there was a talk how we could make it more scalable. So there are apps that people could use, but also, so in Birmingham we've got CBTI for insomnia, and it's a very simple treatment. You don't need psychologists to do the therapy. It can be the nurse. Training is very, very straightforward, and it would be helpful. But yeah, it's sort of changing probably the mindset.
Is daraxonide available now
Yes, it is.
Yeah.
And is it, oh, I've only heard about it today. And where does it stand on like the, first use this melatonin or,
So it's sort of, well, so it's considered to be for chronic insomnia, and it's considered when either CBTI didn't work or it's not available. But also I think with this sort of, obviously we should not be prescribing for elderly, pregnant women, breastfeeding women, and also ideally would like to make sure that the person does not have symptoms of comorbid sleep disorder, because even sleep apnea can present as insomnia.
oh, so the reduroxin is not for elderly?
No, for patients over 55 would be melatonin.
Oh, that's why maybe
Do you see children in your service?
No, we don't. So the children, there is children's sort of, there is a neurologist who works in Birmingham Children's Hospital, and she set up a sleep clinic in her own free time for children, and there is the Evelina Centre in London.
Because in general adult we face a problem, patients graduate of camps started on melatonin, and when our pharmacist would say no, it's not licensed,
Yeah.
we cannot continue with that, and we have a dilemma.
There is the same dilemma in Birmingham sleep clinics. So the graduates from camps going to sleep disorders. So what probably would be sort of what we sort of the way we tend to approach it. So we see those patients in the clinic once, review the situation, what was the reason that they were prescribed melatonin, and to decide whether they still actually need it. And that sort of decision would be made by the sleep physician. And then if they think that they will need it for a sort of circadian rhythm disorder, so let's just put delayed phase disorder, then we would ask GPs to prescribe it, and in Birmingham GPs just started prescribing melatonin, but it's a little bit patchy, so some GPs are happy to prescribe it, some don't, so it varies.
I was just going to say about the prescribing metformin for insomnia. So it comes quite a lot of people being prescribed like quetiapine, 75 milligrams, 50 milligrams for insomnia. I work in acute department, but I've also prescribed it personally for insomnia. Admittedly, I just have comorbid mental health conditions. But what I see quite a lot in acute is Zoficlone being prescribed. It says there like you shouldn't be prescribed for more than this amount of time. You get patients that are on it for like 12, 18 months.
Yeah.
And it's just like, what kind of effect does that have in life? And obviously it makes it difficult to discharge as well, because you have to be really comfortable prescribing that in the community. Like, are we actually affecting like the dependence for these people on this medication? And then we even about support when they leave. Like, we get that quite a lot in acute. I get that it's useful in the short term, like to have like a partner that has bipolar disorder, and you can use it short term, particularly during manifestos. But I just feel like you're doing a bit of a disservice there, maybe. So
Yeah.
what's the alternative? Like, what could we be different?
Well, what probably when we, I mean, it's difficult in an acute situation, but when we sort of prescribe hypnotic, we always say, this is not your long-term solution. I would say those who end up on Zopiclone for a very long time, I would suggest refer them to sleep centre. So what we would do in sort of sleep centre in Birmingham, and so it was the same in St Thomas, if somebody has been taking Zopiclone for a very long time, we would not stop it straight away. We would say, well, you can have it, because people are so dependent, and they say, well, I don't sleep and you're taking even this away from me, and they feel very, very upset about it. So on some, in some situations, not always, we allow them to continue to take Zopiclone for a short period of time to help them to engage with cognitive behavioural therapy for insomnia. But then we say, when we treat that, then obviously we'll have to think about stopping. And obviously, if we do polysomnography, again, we need to wean off medications, because that would affect the sleep architecture as well. So, it's certainly not a long-term solution, but in real life, this happens quite a lot.
So you would suggest, even if somebody, because I get a lot of patients with 15 milligrams of metazapine come to me, an old age psychiatrist, and I have great difficulty taking them off it, because the same argument, I've been on it, I can't sleep, you're taking this away. So would you suggest suggest that they should start CBTI in the presence of mirtazapine?
Well, mirtazapine is sort of it's antidepressant, so CBTI is sort of first line for everybody, but if we want to go down medication route for
No,
older...
I wouldn't have prescribed it.
Yeah.
They come to me.
Mhm.
So rather than, you can't take them off because they're
Yeah.
scared of, like that being taken away, almost becoming dependent. So rather than taking that away, would you suggest that the CBTI should be initiated, and when they get probably better with that, then take the mirtazapine away?
We could do that. It depends how the patient feels about it. If they're particularly anxious, we could say, well, okay, you can carry on for a little bit. If they're not particularly bothered, because some people will come and say, well, I've got this medication, doesn't work. So they might not be particularly worried about stopping it, so it depends. But melatonin works very well for older adults.
Yes. I mean, but sometimes GPs refuse because after 13 weeks, so they then come back with mirtazapine.
Yeah, and obviously there's another sort of important perhaps to note that so other conditions as we age in older adults, sort of such as REM behavioural sleep disorder, especially more common in Parkinson's disease, sleep apnea, particularly in women, has a lot higher rates. Circadian rhythm disorders, so people tend to wake up a little bit earlier as they're becoming old. So the treatment would be a little bit different. And especially with sort of older adults, it's important that if they do have sleep apnea, that it is diagnosed and managed, because that's actually can help sort of improve their condition, and it is a modifying, one of the modifying risk factors for developing dementia.
Why is melatonin not licensed in below 55? Was it just the studies were not done, or was it something? Melatonin can be given for people who are younger than 55 years of age if they have circadian rhythm disorders such as delayed sleep phase disorder. The reason why there is a suggestion for insomnia to prescribe melatonin for patients over 55 years of age is because our circadian system in the brain ages. So, everybody who reaches the age of 55, the circadian rhythm in the brain, sort of the whole system is ages. So therefore, melatonin is helpful.
Thank you. Yeah. Just in terms of practical notes, I suppose, a practical question. So, one take-home message I'm getting is pharmacological options probably shouldn't be used long-term in most cases. And from what I've seen, my few years of limited experience, I've seen loads and loads of patients, like everybody said, on quetiapine, mirtazapine. I've seen loads and loads of kids on melatonin. Sorry. We couldn't possibly refer them all to a sleep clinic, I think. But in terms of sort of de-prescribing in these patients, it's something you'd recommend. Typically talk to them about starting to look at the lifestyle changes, start looking at the possibility of CBTI, and actually actively trying to take people off them. And then the follow-up to that would be, should we be sending advice letters? Because, to our GP colleagues, how many times have we had a referral that, the patient has been, suffering with sleep, we've commenced on mirtazapine, please can you further advise? And they started mirtazapine for sleep, for example. Should we be responding? Should consultant colleagues be responding to GP colleagues with advice?
I would suggest so I worked as a CMHT consultant as well. So when I was getting letters from GP that somebody, struggles with sleep and, can you please advise? My advice would be, well, this person should be referred to a sleep clinic.
Still referred
So, yeah, still referred to sleep clinic. It depends how confident you are, but if particularly for teenagers, if you see somebody that struggles with their academic work, they can't get up for lectures or lessons, and the life is extremely disrupted because they just can't get up in the morning and they're up until 3 a.m. at night, and all sleep hygiene measures fail. I would suggest we could think about melatonin, but only if we are confident to diagnose somebody with delayed sleep phase sort of disorder, which is circadian rhythm disorder. But I know it's very difficult in real life. So, thank you. Okay, thank you.